Good evening, everybody, and a happy new year to you. My name's Nigel Giam. Thank you so much for joining us this evening. I hope you had a great Christmas and got some rest over that period of time. So now, obviously, a very big year for the majority of you who will be CCTing, fingers crossed, with the pass in this SCA, but it's not been an easy time. We've learnt a lot of lessons from the November sitting. Unfortunately, the pass rate was not good. Certainly, it's not the CSA, it's not the RCA. The SCA pass rate in November was pretty low, about 10% lower than we would expect for a CSA face-to-face exam. And we do need to talk about that this evening because it is not the same as the CSA, despite what many people have said. So let's start and we will continue. If people want to record this, I'm afraid that's not going to happen because this is obviously something that is being offered as goodwill, and so do sit back and just absorb it. I'm the lead JP training program director for St Mary's, so I've been a TPD for 17 years. I'm also a CSA, RCA, SCA trainer, amongst other things. And I want to share some experiences with you as we launch into this evening. Some of you have attended my previous strategy webinar, so there will be duplication. This was really prioritized for people who have not attended and those who are resitting. We're going to be looking at a quick intro, top tips. Tonight we are going to attempt to do a big deep dive into RCGP SCA case with group marking and discuss two candidates' performances with a case. Ground rules: use the chat function. I'll answer any of your questions. Please don't request to record the webinar, as there is no recording of this webinar. I'm trying to record it from my side, and if it's successful, it will be published. Just sit back, try and absorb it. Lots of constructive discussion tonight, please, and let's move forward. So narratives all begin, I suppose, with our own. I took this exam well over 20 years ago when it existed as the old RCA in the context of VHS recordings. So this gives you an indication just as to how ancient I am. But I recorded for several months before going to an RCGP course, and really felt that my recordings were up to scratch, but was told in very frank terms by an RCGP examiner that although I'm a very nice doctor, I did not have any idea as to what the exam actually entailed, and none of my cases would be suitable for submission. And that left me about 10 days to get my act together, and obviously a little bit distraught, but I did manage to get my act together, and fortunately I was able to attain a distinction in that module and a distinction overall. But I felt there were a lot of mixed messages out there, and no doubt you probably feel that that is also the case, especially those of you who are attending tonight that have already been stung, perhaps in the RCA and now in this first sitting in the SCA. So I worked as an RCGP course director alongside examiners such as Roger Neighbour, really teaching consultation skills, assessing consultation skills, and I really want to share a lot of that experience with you this evening. So the CSA was a face-to-face exam. About half of it was diagnostic driven. This is not a diagnostic driven exam, the SCA, because physical examination has no part to play whatsoever in the context of the management of risk. Therefore, if you are sitting right now in your study groups just saying, well, we're going to do cardiology, ENT, abdo, and you're just chasing a diagnosis, I'm very sorry to say that is a sure way to fail, because you are revising and studying in the wrong way, and all that's going to do is essentially consolidate rigid symptom diagnostic driven behavior. This is a narrative driven exam, and this is already clear from the people that have passed this exam that actually you're going to be tested on competencies around negotiation skills, self-awareness, situational awareness, case priming, understanding what you do with the 3 minutes that you have. And we have, or certainly the course Mentor MRCGP now has seen through thousands of people through the MRCGP, and certainly a huge amount of very successful STs, top scorers, top 1% scoring 100 plus through the SCA. We'll showcase an interview with one of those top scorers who really dissects how to optimize your marks in the 3 domains. And what's interesting from that top scorer very specifically is that he emphasizes and re-emphasizes that this is not a symptom-driven diagnostic exam. So your study groups have to change and they have to adapt to the remote consultation. So let's just do a quick poll at this point to see how many of you are actually consulting remotely. So I'm going to launch the poll, and I'd like you all to answer right now, please. Are you undertaking practicing video consultations regularly? So we'll try and get it up to about 90% before we stop the poll. Thank you so much for participating. Okay, so we're at 89%, 92%. All right, so I'm just going to stop the poll at this point. Thank you very much for answering. And I'll just share the results there with you. So 2/3 of you are not regularly practicing or undertaking video consultations, and about 1/3 of you are. So that's very interesting, isn't it? Because, you know, ultimately, if you aren't practicing this on a regular basis, if you're just sitting in a study group face to face, you're revising in the wrong way. It's not a CSA. So with my trainees, certainly at St Mary's, you know, if we practice face to face, and I run regular study groups with my trainees, then we will never ever do a face to face consultation, because it's a waste of time. We'll do it back to back. We have to mimic the audio consultation. 2/3 of your consultations are going to be over video. That is not the same as face to face, no matter what anyone says to you, you know, in the context of how you pick up verbal and non-verbal cues. So be very strategic with how you start revising in the right way, and do decide what you want to believe, because it's not topic based. You know, you're going to be assessed on the SCA blueprint. And if you are picking cases and you haven't mapped that to the SCA blueprint, if you have not mapped that to the SCA mark sheet, then actually how are you giving feedback objectively? The worst thing you can say to your colleagues is, you know, you're very nice, you're very good. That means nothing. It means absolutely nothing. You know, are you actually mapping to the marking SCA competencies? Are you marking to the grid? Are you picking cases that map to the blueprint? So we will talk about this in more detail as we move along. So the majority of you will be sitting this later in the year, some of you very imminently. If you're attending tonight and you're sitting this next week, well, I hope you get something from this. But, you know, ultimately you need time to change, and that means 3 months of very strategic practice. If you're not practicing the right way, then all you're doing is essentially colluding, and collusion can be very, very dangerous. This isn't an OSCE. You don't get marks for asking smoking, alcohol, what do you do for work, who lives at home. In fact, you lose marks because it's a summative assessment. So if you have a look at the SCA mark sheet, it is very specific about this. You know, it is very specific about formulaic consultation behavior. Are you calling your colleagues out in this in your study groups? You know, are you saying to your colleagues, you know, hold on a second, why did you ask me about smoking? What's that got to do with anything? If you're not doing that, then you're not doing yourself any favors, because you're just colluding. So it's very important that actually you recognize it's not an OSCE. There's no question that gives you a tick. You're being assessed on behaviors. Behaviors by default have to be contextual and reactive to the narrative that is panning out in front of you. Yes, I understand that's difficult when you're nervous. You're trying to solve the problem. You're trying to engage the patient. But if it doesn't feel real, if all you're doing is processing, and every single one of you has a processing word, your processing word will be something like this. Okay, sure, fine. I'm so worried about this headache, doctor. Okay, fine. No, it's not okay, actually. It's not fine. As opposed to actually acknowledging what's panning out in front of you, having a conversation, saying what you see, meaning what you say. So you have to be in the moment. You are being assessed on narratives, and the mantras that I'm going to just start alluding to tonight to help you. 3 mantras I teach on my masterclass course, 3 mantras to help you deal with anything that walks in through the door, are completely narrative driven. They've got nothing to do with the symptom. They've got nothing to do with the diagnosis. They are to do with situational awareness. They are to do with knowing your place in the patient's timeline with the 3 minutes that you have to look at the notes. So it's got to feel real. And it's not a typical clinic, because we've already seen, you know, if it was a typical clinic, you would be, you know, consulting every patient remotely. You're not doing that. You're seeing patients face to face, but it is meant to reflect real life. That is to say, these presentations that are coming in through the door should and will come in through the door at some point in your GP career. And for that reason, you cannot rush this exam. Too many people rush it. They rush it because they think, you know, either I want to get it out of the way, I want to get experience, but do not underestimate a failure, because a failure will have huge impact both on you, your morale, and more importantly, the people around you. So right now, you know, we're looking at quite a huge failure rate, and obviously we are bottlenecking people who are close to finishing CCT, who failed the RCA, failed the SCA November. So the next few sittings, January, February, are going to be very, very busy, and you cannot rush this. So time management isn't just paramount in the consultation, it's paramount in how you prepare. You can't learn the SCA from a book. Knowing how to stay in control of the consultation is key, and the analogy is very simple. It's a car journey. You're the driver, the patient's in the passenger seat, but the difference between the SCA versus the CSA is that journey has started with another healthcare professional. That journey has started in the patient's notes, and we will showcase this tonight. Now, at this point, I would really like you all, if you're able to, hopefully you're not driving yourself, you're in a safe environment, to take out a piece of paper. That piece of paper is going to mimic your whiteboard, and you're going to use that very strategically. And I'm going to teach you how to come up with an SCA battle plan in the 3 minutes that you have before you consult with the patient. Because if you do not have a battle plan in those 3 minutes, if you do not prime your case and you're going in blind, you will get stung. Physical examination, I repeat, has no place to play in this exam. In other words, you cannot depend or sit on the fence on an examination or an investigation before you make a commitment to risk first and foremost. And it is risk that we are looking to see with regards to how you manage. We are looking for reactive practitioners, those who are reactive to risk. There are only 3 levels of risk. Can you recognize what's serious enough to warrant escalation today, stroke admission? Or second level, serious enough to warrant urgent review, urgent investigations, maybe a 2-week wait. Or if it's not serious, your job is to risk contain this and not compromise budgetary governance, inappropriate investigations, inappropriate referrals. So you have to get to point B, but understand that you are coming into the journey and the narrative later. So that all sounds tough. It's tough. The pass rates or failure rates have already spoken for themselves. But you know, the way that I teach this is not this way, it is this way. That is not to say we don't demonstrate tough love on the masterclass course. We demonstrate a lot of tough love because you want to know what you're doing wrong and how to fix it, as opposed to necessarily what you're doing right all the time. Because actually, if you can identify what you're doing wrong, you're in a position to fix it. But you do have to fix it. And that means actually demonstrating not just resilience, but it's actually about energy. Energy is the key. Because actually transference, how you make a patient feel, depends on how you feel. That's difficult over the virtual forum, isn't it? But ultimately, you're the drug in this consultation. If you're just going through the motions of saying words, not thinking about your tonation, not just what you say, but how you say it, then there will be no energy. So we teach this acronym on the course, AEE. Any emotive situation, acknowledge the emotion panning out in front of you. I can see that you're concerned. Be curious about the cue. The cue is king in the consultation. The great thing about the SCA, there's not many great things, but the great thing is it's a standardized exam. And that helps us. Why? Because every patient's going to have a component of ICE built into their role play. Therefore, it's your interest to be curious about that, to use it to focus your history so that you can readdress it. And if the situation becomes emotive, you acknowledge the emotion, you empathize with the situation, and then you energize, AEE. Acknowledge, empathize, energize. What can you do to help? Always trying to drive the consultation forward. 9 videos, 3 audios, 12 by 12, 3 minutes to prime. Recognize it's not a typical clinic. You'll be consulting with third parties, anxious parents, maybe healthcare workers, social workers, district nurses. Everything's recorded, then marked outside of the exam. No cases, I repeat, no cases will require physical examination. That is not to say you don't necessarily bring in a patient for examination, but it should not compromise how you commit to risk. Your history alone should allow you to commit to risk. You need to have a paper copy of the BNF, difficult because it's going out of publication soon. Whiteboard, you've got that tonight, plain piece of A4 paper in front of you, which we are going to use very shortly. No crib sheets. And then let's talk about the marking system. Right, on the top, remote video. On the bottom, remote audio. Remote video, your top left, patient in the center, you've got case notes on the right, you've got a virtual whiteboard on the bottom, you've got a timer on the left. There is a lot of stuff happening there on one screen. No 2 screens, one screen. So we use our 3 minutes to look at the notes, we try and minimize the notes, then we focus on the patient. If it's audio, you stay on board, patient's off, keep the case notes up, screen is less busy. Blueprint. What do we teach you on the masterclass? teenagers, gender, reproductive, sexual health, long-term conditions, older adults, mental health, drug dependency, urgent unscheduled care, mental capacity, health disadvantage, safeguarding, ethnicity, diversity, new presentation of undifferentiated disease, prescribing, going through investigations and results, professional conversation, professional dilemma. Where in this blueprint does it say we're going to test you on cardiovascular, ENT, abdo, respiratory? No, it doesn't come anywhere, does it? So that's the whole point. If you are revising topic-based, completely wrong, okay? You need to go by the blueprint. That isn't to say you're not going to get undifferentiated cardiovascular disease or undifferentiated respiratory problems or long-term conditions that involve cardiovascular and respiratory. That's fine. You can absolutely do that, but you have to always map it to the blueprint. Next rule of the SCA, the word dilemma. The most powerful word in this exam. Its existence in the conception of the MRCGP through the old Vivas, which I was involved in, through to the CSA, RCA. Now it's in your blueprint. You will negotiate a lot in this exam. All you need to do is just watch that sample video, that interview I've done with Attar, who scored 101. It's on the YouTube, and he'll tell you, it's from the horse's mouth. Negotiated at least 50-60% of the cases. Patients who know what they want, not what they need. So here's a golden rule, okay? If a patient's opening statement in the SCA is, I want this, and you give it to them, you failed. It's as simple as that. Because you've got a dilemma, all right? There is a difference between being patient-driven and being patient-centered. So learning how to work on these skills is very, very important, right? We're going to do a test. We'll attempt to do a test with a number of you this evening. Let's try it out, shall we? And we're going to use the chat group. So please, I would like you now to use your whiteboard. Okay, you're going to have a minute to document whatever you feel is important from the following candidate briefing. And this is coming from the RCGP SCA case. 1 minute, and then we're going to have 2 minutes to look at the patient's notes. And again, you'll document your information, and then we will map it to the blueprint. And the more you put into this webinar tonight, the more you're going to understand where the bar is in terms of passing. So here we go. You've got 1 minute. Document what you think is important from this candidate briefing, please. So you'll document, and then I'll ask you some questions, and then we'll use the chat group to see who has actually got a battle plan together. So we've got about another 20 seconds, and then I am going to be putting up the patient's notes, and you're going to have a bit longer to have a look-see. Okay, so the patient's notes are now coming up. Again, use your whiteboard to document what you feel might be important, and then we're going to map it to the blueprint, and then we're going to come up with a battle plan. Here are the patient's notes coming up. You've got about another 30 seconds, and then we'll see who's actually being strategic about this. All right, I'm going to stop the share, or rather we're going to move on firstly. Okay, in the chat group, what was the name and age of this patient, please? You've got to be in it to win it. So let's see who's actually being strategic here tonight. Let's see who the first one is. Come on, the patient's already started. It's not Mr. Ellis. No, it's Mr. McLean. Where do we get Mr. Ellis from? Mr. McLean, 75 years old. And what was his examination findings from the district nurse today? What is the most important examination findings that were given today by Mr. McLean? A postural drop in his blood pressure. Okay, so what exactly was his blood pressure today, please? I want to know the most important thing. 100, thank you, Syed. Okay, what was his blood pressure 3 months ago? What was his blood pressure 3 months ago? 148 over, so lots of different things. 148 over 62, okay. And what long-term conditions does this patient have? Diabetes, hypertension, CKD stage 3. What medications does he have? What medications is he on? He's on an ARB, he's on metformin, okay. And what his social circumstances? What's happening at home for him? He's the carer, right. Let's choose a blueprint, shall we? Let's see what you guys think you're being tested on with this patient. So older adults, what else? Just choose a number. Choose a number from the blueprint. It's in front of you. Number 3, number 12. Okay, I've got from one person, number 6, Francis. Thank you. Francis being someone that studied with me at VTS long time ago. Lovely to have you here, Francis, this evening. So, Francis, Annette, you've also basically said urgent unscheduled care. Faraday also, Syed too. And I guess why is that? Why is that? Because I've got an acutely unwell patient who might require risk escalation. Prescribing certainly is important because they might be in AKI. Do you think they will want to be risk escalated to hospital? Yes or no? No. Why? Because they're a carer for their wife. Therefore, you've got a dilemma, don't you? So that's what you're being assessed on. You're going to be assessed on urgent unscheduled care, prescribing, and working through a dilemma. That's what you're going to be assessed on. Situational awareness. In other words, you're about to go into a negotiation station. Now, if you didn't think about that in the 3 minutes that you had, you're going to get stung. And if you don't believe me, all you need to do is watch the registrar on the RCGP website who approached this case, who is just chasing a symptom and chasing their tail for 8-9 minutes and are completely lost because they didn't prime the case and they did not have a battle plan. Now, when you watch these cases, and we're going to watch one tonight, by the way, and you're all going to mark it, all right? Recognize that actually the college do not tell you whether it's a pass or fail. Not very useful, is it? But actually what is useful is the discussion that entails. So, did you prime the case? This is not my stuff. This is just from the college, okay? Did you notice the difference in the blood pressure regions? Did you recognize the risk about AKI? Specifically, was there a need for further examination and the urgency around this? Did you specifically think about the medication management steps? What were the patient's priorities and his social situation and the solutions? What do I mean by priming? Priming is about using the information that you have to understand where you are in the patient's narrative, understanding how you map it to the blueprint and having a battle plan. Priming is not there twiddling your thumbs for 3 minutes thinking, oh, I wonder what's going to come in through the door now. Okay, you're given that information, you're given it for a reason, and you're given a hell of a lot of information, much more compared to a face-to-face CSA. So if you don't prime, if you don't get your battle plans together, if you don't have a strategy, if you're not always thinking about the blueprint, then actually you're going to get stung. And we're going to see this. Let's talk about how a role play is written up, okay? Because actually when a role play is written up, it has to follow certain rules. Information can only be given if it's specifically asked for. So if you just keep saying, tell me more, tell me more, tell me more, it's just going to be met with, what do you want to know? What do you want to know? What do you want to know? Any other symptoms? What does that mean? Anything I've missed you want to tell me so I can pass this blasted SCA exam? Well, there's plenty of things that you missed, but I can't tell you unless you specifically ask me. There's no such thing as a golden minute in this exam. It's a golden 15 seconds. Every minute that you're in there costs you £10. Yeah, so don't over-summarize. Over-summaries highlight one thing only. Everything that you've missed, and they highlight it to the examiner. Why would you highlight to the examiner everything that you've missed? So be very careful. All you want to do is recognize that the cue is the king in the consultation, and cues, this is the next most important rule in the SCA, can only be dropped twice in a standardized exam. If you don't pick up the cue the second time, it's gone. If your brain is already saying, I'll talk about that later, your history, talk about it now. You talk about it now, it'll take you to where you need to be. It's a conversation, and in conversation, you listen, you react. It's a game of ping pong. Your next question will reveal itself in the statement, in the answer, in the response that's coming back over the net. So your technique is key. If you're going quantity, 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 forget it. It's not the AKT. AKT is about quantity. It's also about strategy and practice. It's about quality. My VTS, we practice 30 cases. That's it. 30 cases again and again and again. I'll get my registrars to practice it 20 times over until I am satisfied they are getting clear passes in all those 3 domains. There is no point in moving on until the right critique has been given, the right construction has been given, and we break you out of bad habits. If you are colluding, if you're just going through a casebook, that is a sure way to fail, because all you're doing is just going through a case, not the narrative, and you're not changing your technique. Presentation, tonation, not just what you say, how you say it. It's all in the power of that presentation, not just the words. Words are very powerful, but how you say those words, even more powerful. And that's why, you know, when we start looking at differential attainment, there's no point in hiding behind, you know, saying, oh, you know, what's going on differential attainment. It's been overcomplicated. If English isn't your first language and this is a test of communication, then yes, it's going to be tough, but it's not impossible. Less is always more. It's very important not to focus on the diagnosis. Have a conversation. Imagine you're having a conversation in your mother tongue. How do you translate that now to the patient that's opposite you? You want to be talking with your patient, not at your patient. So it's very, very important, okay? Don't get into that diagnostic mode. Right, let's talk about the practicalities. We know so much more now in terms of the marking. So the 3 domains, data gathering, clinical management, relating to others. Clinical domain carries 1.5 times more marks compared to data gathering and relating to others. Tonight, we're going to keep it simple. We'll still go by the 4 grades, which still apply anyway: clear pass, pass, fail, clear, fail. Globally, the examiner will also rate you as a pass, fail, or fail. On my course, we keep it simple. So a clear pass is a 3, pass is a 2, fail is a 1, clear, fail is a 0. Magic number is 6 out of 9. Pass mark, 9 out of 9. Your job to get into the mid-70s. Okay. Pass mark determined by the borderline group method and then released back to your e-portfolio. Let's give you a snapshot of one of our top scorers, Attar, who I mentored for a couple of months. He took the exam early for personal reasons, scored 101, really smashed it out. Yes, clinical management could have been stronger, but hey, it's 101. Only the top 1% of the country get that. So let's have a look at some of the sorts of cases that have come through. So father regarding unwell 3-year-old child, and that's not about a diagnosis. You know, that could well be about an angry dad, mood, after the birth of the first baby, situational awareness. Obviously, we can't go into the details of this, you know, and certainly I've not discussed the details because that's not allowed, but I'm just giving you a flavor that this is not diagnostic driven. There are narratives behind this. There's always a story before a symptom, and I really would advise you to watch this very enlightening interview. It's only 15 minutes with Attar on the YouTube channel. Do subscribe to it. You know, it's going to give you a lot of good top tips as to how to approach each of those domains and maximize those marks, especially if you're going to be sitting it imminently or in the next few months. When the original SCA statements came out, they were really, really scary. So we specifically looked at, you know, I suppose these aspects around negotiation skills, not taking ownership, not understanding the impact of the problem on the patient and the family, not actually understanding the medical legal implications. I mean, medical legal implications. So you're going to be assessed on professional conversations, fitness to practice, and then clinical management, investigations, inappropriate, risk averse, inappropriate resources being used, not managing risk reactively. And then here, someone was asking about case priming. Here's case priming: ineffective use of existing information to assist in how you gather data, prioritize data to ensure it's reactive and safe. Therefore, understand your place in the patient's narrative. Tonight, all of you should have downloaded this mark sheet. I am putting it now in the chat group. Download it now, please, because you will be using it very shortly as we do a big group marking exercise when we look at a case calibration. Let's work through some of these statements. Case priming, using those notes early on, contextually, reactively, so you can prioritize your data so it is systematic, making sure specifically that when you ask questions, they are contextual, they are always thinking about risk. That ultimately, you know, if there is a differential to be put out there, we put it out there, we commit to it. But ultimately, it is about the management of risk that is key, as opposed to just the diagnosis. Is your management reactive to that level of risk? Because if it's not, and you're risk averse and you're over referring, you will compromise your clinical management domain. Making sure that you manage uncertainty with confidence, you share that you think about how you manage your time effectively within the consultation. We look really at a 7 to 5 minute split. That's how I teach it on the course. But if you are entering that clinical management with only kind of 3 minutes to spare, you're going to be very pushed for time. Dangerous, given that the clinical management section is 1.5 times more weighted compared to the other domains. And then ultimately, are you interested in ICE? And when I say interested, not going through the motions of just asking it, but actively listening it, using it. If that patient's worried about a brain tumor, are you using that health anxiety to focus down on those neurological red flags of the system so you can readdress that? Are you showing situational awareness? Are you managing the patient's narrative as opposed to just the symptom? Are you taking ownership for it? Are you recognizing when you're being tested on risk and safeguarding? So here's the first mantra. I'm going to touch on 3 mantras tonight briefly. We go into a lot more depth on this on the course, and these mantras will keep you very, very safe. You know, everyone who's come through, you know, has been very kind, because these mantras have been developed over the last 22 years, and they're mantras to be used in real life always. Patients coming with symptoms, but do not get caught up with the symptom. Understand the narrative that's led up to that. That may well have started in the patient's notes. It's in your interest to open up the patient's ICE earlier so you can use it. Don't over ICE. So a lot of mixed messages. Oh, I ask ICE about 6-7 minutes. Why would you do that? You know, if you do that, you can't do anything with it. It's too late. Wouldn't you rather know earlier that the patient's worried about a brain tumor so you can actually do something with that information, so you can use it, so you can readdress it? When we ask about the symptom, make sure your questions are single-barreled. It's a game of ping pong. Don't throw 20 ping pong balls at your patient. I don't want multi-barrel questions. One question, one response. We can use the health anxiety to focus down on the system that we're interested in. Keep your language neutral. Don't say things like sinister. Sinister's terrible. The word sinister means evil. Just to make sure I'm not missing anything too sinister here. What? As opposed to, okay, so I appreciate you were worried about this. I'll ask you a few questions just to make sure we're not missing anything else. Keep your language neutral. If you're jumping systems into sexual health, be clear why you're doing that. Don't just go, can I ask a few personal questions? Be clear why you want to ask personal questions. Given that you've had some symptoms with regards, you know, vaginal discharge, can I ask a few routine questions around your sexual health? Is a good signpost. Do not crowbar in smoking and alcohol. Signpost those questions so contextually they have a place to play. AEE, anything that's emotive, acknowledge the emotion, empathize with the situation, energize, understand the situation around the patient. Don't just say what you do for work, who lives with you at home. If these questions are crowbarred in, you do not get marks. Marks are taken away. They are taken away because it is not a tick box exercise. Do not over summarize. Stay close to the theme of the case. And then 3 things coming in. The patient was worried about a brain tumor. They wanted an MRI scan. Readdress that first before you share your own thought processes. And then you can start thinking about how you commit, but not to the diagnosis. Commitment to risk. Especially if you're thinking of potentially something serious. The word cancer is a big word. You're jumping into the deep end of a swimming pool. You're going to drown there. You start in the shallow end and then you move up. The patient thinks it's piles. You need to keep an open mind just to make sure you're not missing anything else. We start talking about perhaps doing an up-to-date fit test. We justify why we're doing that because it's a screening test to make sure we're not missing other potentially serious causes such as cancer. That word scares your patient. They begin to sink in that swimming pool. It's a motive. What you do, you AEE, you acknowledge the emotion. I can see you're not expecting to have this conversation today. You empathize with it. I'm sorry, I didn't mean to shock you by it. And then you energize. I'm not saying this is cancer at all, but just something we need to be mindful of. And it's good that you've made this appointment today. We're in a position to look into what's going on, and we're here to help you with that. So you surface again with your patient and you get to point B, always thinking about your tonation, your self-awareness, your words, your actions will have reactions, and you are responsible for those reactions. So anticipate them. Think about transference and energy. Most important mantra then, story symptom system. Alongside this, we have 2 other mantras. You know from the blueprint you're going to get results. You need to give those results. How often have you been a patient under the NHS? I've been a patient 100 times, okay? And if I've had a scan, guess what I want? I want the results of my scan. That's what I want. I don't want to be talking about what's already been talked about. So have a look at the notes. Understand what led to the test. Prime your case. Is there any information in your notes as to what was discussed? Did the patient have any particular concerns? Deliver the result quickly, okay? And once you've delivered the result, you can go back in to story symptom system to put those results into context. You deliver that result at 5 minutes, you failed the case, I can guarantee you. You get that result out, okay? So, Mr. Smith, I can see this is what's led to the test. Can I just clarify what was discussed with the GP, and did you have any concerns? Right. Well, let's just go over the results right now. And then what might need to do is ask you some questions just so that I can put the result into context for you. And then finally, the other mantra, negotiation, which we know you are going to be faced with a lot in this exam. And the word dilemma is a buzzword. It's an examiner buzzword. It's in your blueprint. So use it. Use it whenever a patient knows what they want as opposed to what they need. Again, that opening statement, I want this. Then you have a dilemma. Understand what the dilemma might be. Is it a risk versus benefit thing? Patient wants diazepam. Are we being assessed on drug dependency? Or I want this referral. Is it budgetary governance? Or I want this to be completely confidential. Is it defined by the GMC? Can you depersonalize the dilemma? But if you say no, do it in a nice, firm and fair way. Have something else to barter with. So for example, we're coming in, we're telling the patient they don't need that MRI scan. We're telling them it's a tension headache. It's not too serious. They say, I don't care. I want to have the MRI scan. Then you have a dilemma. Then you've got a negotiation on your hands. Okay. A couple more slides and then we're going to do this. We're going to attempt this marking, this big marking tonight. Being patient-centered is not the same as being patient-driven. Being patient-centered ultimately is about how you use ICE so that you can readdress it, okay? So it's very important that you ask it in context, you actively listen, you don't over ICE, you stay close to it, you use it, but also recognize that sometimes you cannot meet it. So recognize if a patient has a very set agenda, then actually we may have a dilemma. And if that is the case, we define what the dilemma is, we define who's defining it, because it may not be me, it could be the GMC, it could be the DVLA. We negotiate and we come up with a compromise. Being patient-centered is also about informed decision-making. It isn't about saying, here are options, you pick. That's not a patient-centered decision. So with regards to depression, we've got antidepressants, we've got CBT, what do you prefer? That's not a patient-centered discussion. A patient-centered discussion has to be an informed one. With regards to depression, yes, there's the option of antidepressants, but they take a bit of time to work. Sometimes patients feel worse before they feel better. And if we're going down that route, it's really about 6 months of treatment to get the optimal effect. We always advocate talking therapies is a patient-centered discussion. Right. Energy, energy, energy. It's all in the eyes. Let's think about the blueprint. Have you got your scratch pad and A4 piece of paper in front of you? Because you're going to need it right now. You have 2 minutes to make your notes, and this one we're going to watch together. Here we go. Take your notes. So I've got Gerry Freeman, 82, lots of comorbidities. So I'm thinking about long-term conditions, but I'm also seeing a lot of medications. So in my mind, I'm already thinking about the prescribing blueprint. Everything has seemed relatively stable. He's 82, he's retired, married with 2 adult children, but I don't know what the setup is at home. So I need to think about also that older adult and frailty blueprint. But he submitted a photo, a rash, so I've got undifferentiated disease as well. So far in my blueprint, I'm putting at the top here prescribing. I'm also thinking about risk management because potentially of the comorbidities and his age, and I've got undifferentiated disease. So I'm priming. Let's have a look at the rash.